Michigan. Very exciting. Well, thank you, everyone. We'll go ahead and get started since we are just at the top of the hour. Thank you all for joining, taking time out of your afternoon to join. My name is Catherine Pugh. I'm the Assistant Vice President of Policy at Executives for Health Innovation, or EHI. And you are joining for the third in our series of educational webinars on public health modernization. So it's our public health modernization series. And today's topic is the use of innovative technologies in public health. Next slide. So if you don't know who EHI is, this is your first time joining, we are a catalyst for healthcare transformation, and we convene diverse leaders from across the industry to unlock opportunities for collaborative innovation. And our members, if you can go to the next slide. Oh, sorry, excuse me, our member, there we go. Our members really represent a wide swath of the healthcare and technology industry. And then Emma, if you go back a slide, excuse me, our focus areas are right here on the slides: modernizing public health, health equity, virtual care, privacy and security. Okay. And then we have a list of our upcoming events. If you'd like to join us for our next webinars, you can go to our website, ehidc.org/events, and you can register for any of those upcoming webinars. And then also on our website and our resource center, we have recordings from our first two public health webinars. The first was what the pandemic exposed and taught us about our public health system, which is a general overview of the impact of COVID on the public health system. Next slide. And then our second was focused on data privacy and public health. It was a great webinar facilitated by my colleague, Alice Leiter, who was our privacy counsel, excuse me. And the recording of both of those are available in the resource center on our website. Next slide. Okay, which brings us to today's webinar. I'm really excited to be joined by two experts in public health and technology. First, we have Betsy Baker. Betsy is a business development manager for Amazon Web Services, state and local government team, and she engages with public healthcare agencies across the US to invent new ways to leverage technology to improve the constituent experience in public health programs and be more prepared to respond to public emergencies. And then we have Dr. John Frownfelter, who's the Chief Medical Officer with Jvion. And previously to this role, he was the Chief Medical Information Officer for inpatient services at Henry Ford Health System and Chief Medical Information Officer with Unity Point Health. And with that, I will turn it over to Betsy for her remarks.
Thanks, Catherine. Hi, everyone. It's really nice to be here today. So thank you for your time this afternoon. I'm a modernization leader on our public health team at Amazon Web Services. So very much focused on trying to get our public health agencies across the US into a little bit more modern IT infrastructure. I come from about a decade of experience in doing this within Medicaid, health information exchange, and most recently public health in the past 26 months. Next slide. So before I dive into some of the stories that I'd like to talk to you all about in the public health arena and how we've been able to modernize at warp speed due to a trigger known as COVID-19, I just want to level set a little bit on some of the concepts that I'll be talking about or saying, or in my answers I may use. And so I just wanted to kind of provide some cloud computing terms that are often used, and for those that are not familiar with cloud computing. So the cloud is not actually in the sky. I like to give class chats presentations, and I love to tell all the elementary kids that it's not actually in the sky. It is data centers that are available through the internet. So we provide computing that is available through the internet. So that AWS kind of cloud box you see provides all the things that you would think a computer would provide if it was sitting on your desk, only it's available through www something. And then we have customers of AWS that provide that software or a platform or management and security, or all the things that kind of sit on top of what you would consider a computer to be. So AWS is the cloud computing service or infrastructure. And then we have customers all over, both in commercial and public sector, that build things on top of the cloud, software components or security components that assist with executing business functions. So we'll talk a little bit more about that today. Next slide. So before COVID, or what I like to call BCL, before COVID life, I spent a lot of time talking to public agencies generally about moving to the cloud because of the 5 reasons that you see here. So I'm not going to spend too much time on this slide, but we would talk a lot about agility and the ability with a cloud computing service to be able to experiment and change directions quickly with low cost and low risk. Our cost savings, you're not procuring a bunch of servers and then putting them in a data center somewhere, hoping they'll be used one day. You only pay for what you use. We would talk about elasticity. So being able to scale up and scale down in a minute, if you will, or using our console very, very quickly. Being able to innovate faster. So again, using that kind of coupling with agility, you can test out different services. You can test services, new services from AWS, things that I'll get into a little bit later, like AI. And you really use your IT folks to focus on business differentiators and building things that are good for your everyday operations and not the infrastructure piece of managing servers and data centers. And then the scalability piece, again, is just allowing for extensive and reliable and secure infrastructure, whether you live in Colorado like I do, or across the nation in different regions of the US, or even globally, if that's what your business needs are. So all of these things were concepts that I talked a lot about, BCL. And then March 2020 hit, and we didn't talk about these at all. We talked about how we get people to work and how we get data into people's homes to keep them safe, still secure though, because obviously in public health, we're working with a lot of sensitive data. And so we really had a trigger in March of 2020 that provided a huge impetus for agencies moving to the cloud. Now, as we kind of come out of the response mode, and I'll tell you a few stories about some of the really impactful cloud movement components during COVID. But now as we come out, we really want to look at how can we use what we learned, the huge gaps that were identified during COVID, in order to help make our response or predictions a little bit better in the future when it comes to public health, population health, and keeping people safe. Next slide. So one big movement during COVID for the cloud computing era was the data lake movement. New York State is a really good example of this. And in May of 2020, they came to us and, in March of 2020, it says May, but that's the number of COVID cases. In March of 2020, they came to us and said, we can't test people fast enough. We have no idea who actually has COVID, where they are, and we can't get electronic lab reports in quick enough, let alone get testing out. So we decided to scrap together a data lake for them. It was stood up in 11 days from kickoff to production data flowing in. And essentially what we did is we looked at the business outcomes and we said, all right, so the key here is that we would like to know who has COVID, where they are, and what their risk may be of expiration, to be quite honest. And so we pulled in electronic lab reporting data that was already flowing into the Department of Health. And then we also coupled that with clinical data that was flowing in from 6 health information exchanges across the state. And we gleaned ICD-10 codes that we believed were related to COVID based on the CDC's analysis, and said, all right, we either have people who are testing positive on the electronic lab reporting, or we have people who we're going to presume are positive with COVID based on their ICD-10 or their diagnosis codes. And so, within 11 days, the department had a much better readout of who we either knew had COVID based on a positive lab test or thought had COVID based on their clinical outcomes. So this proved to be essential in really trying to look at how we could manage COVID within the state, how the department could conduct research on risk factors, and really look at how they could help keep their population a little bit safer while we were still in the early days of understanding what this disease was. Next slide. Another kind of, actually, this is a real glory story, as I like to call them. We have a partner, STC Health, that runs immunization information systems on AWS. And they had the foresight in 2019 to start thinking about cloud movement. And they actually got their last IIS moved to the cloud in January of 2020, which seems, really ironic, but it was a really great move on their part. And essentially what this allowed for is when we had to start looking at vaccine management and rollout, the immunization information systems run on AWS, they were able to add and take away different cloud computing services, as well as scale up and scale down the compute power on these IISs, because as you can imagine, when the COVID-19 vaccination rolled out to everyone in the US, the power needed to compute that data or the queries that were required to query that data increased exponentially. And so this IIS partner that we have, STC Health, by going to the cloud really allowed states using their IIS system to amp up their COVID-19 responses without having to really worry about the infrastructure side, and focused more on really that business side response. Next slide. Disease surveillance systems became very evident that they were very, very important during COVID-19. And a lot of these stories, well, all these stories are from COVID-19, but I hope in our discussion we can parlay that into the future, because hopefully we don't face another one of these anytime soon. And so, especially when talking about disease surveillance systems, this is an E. coli outbreak at a restaurant somewhere. This is a norovirus outbreak at a wedding, potentially. But what we found during the pandemic was that these disease surveillance systems were very siloed. They were fragmented in data. People were coming in via a call center or via electronic lab reporting data with a positive case report, via electronic case reporting. I mean, the data was flowing in from all over the place, and there was a very fragmented way in order to link data together in order to get a real picture of what a disease looked like. So in the state of Minnesota, this became extremely evident as they tried to battle the COVID-19 pandemic. They had things coming in on paper and fax machines. They had electronic lab reporting coming in with positive COVID tests. And then of course the agency shut down. And so they had to figure out how they were going to, I wish I had the picture. They have a picture of this room that they had for their epidemiology department where there was just paper taped up on walls everywhere. And they had to check in and out these folders. So you can imagine that was really, really stressful. And then of course, when the agency shut down, they weren't able to really do much. So we stood up a data lake for them as well. It started as kind of a disease surveillance system data lake where we could bring in paper reports as well as electronic reports and help their epidemiologists really look at kind of the state of the disease. But from there, we actually added on a contact center component for which we could do some outbound calling with contact tracing once we knew there was a positive COVID test. And then it ended up integrating IIS data eventually as well. So they could get a full picture of if someone is immunized, do they test positive for the disease, genetically sequence that disease to figure out if there's a variant that leads to breakthrough. They really can go down a research rabbit hole because the data silos were broken down through kind of creating this aggregated data source for their disease surveillance. Next slide. And then the last thing that we kind of saw, which is non-traditional to public health in general, is contact centers launching. So one, we had a lot of Amazon Connect, which is our cloud-based contact center within AWS, launch only to handle COVID-19 contact tracing, because as you can imagine, if you have an E. coli breakout in a very centralized place, you don't typically have a ton of contact center staff on hand. And so we were able to kind of disperse contact centers across the nation for that type of thing. But this also was used in Alameda County for proactive communication. So we would send out the county, when I say we, it's a really collective we. The county would send out text messages of alerts of, there's a large outbreak of COVID in your case, or there's breakthrough cases, or reminders for immunizations, mask mandate information. So it really allowed them to proactively communicate with 13 cities and 1.5 million people, all while they were working remotely. So people could do this from their homes in a safe and secure way, and proactively communicate with their county constituents so that they engage directly with the public and kind of earn trust around what was going on with the COVID-19 pandemic. So I just kind of wanted to give you a smattering of some of the pandemic stories that were rapid fire modernization stories, in hopes that as we kind of open up into the panel discussion, we can talk a little bit more about the foresight of modernization. Thanks, Catherine.
Thanks so much, Betsy. Now we will turn to John.
Thanks, Catherine, and thanks everyone for your attention. And for those on Central Time Zone, apologize that you're entering the post lunchtime coma. I'll try to keep you awake here. So I'm going to tell a little bit about Jvion first, and go ahead to the next slide. We're an artificial intelligence company that puts patients right in the middle of what we're trying to understand with artificial intelligence and to anticipate and then to prevent negative outcomes. So what does that mean? Anything with artificial intelligence has to have a couple of elements to it. One is a large representative data set, in this case, patients. And secondly, endpoints that we're trying to measure, because it's all, at the end of the day, it's math that's measuring an endpoint that this patient had this event happen or didn't happen. So that's the core of what we do. And that's a competency, if you think of it like that. It can be pointed towards any number of use cases. We've had dozens of use cases, or you might say different models stood up and built. But the agility of it was very valuable in the context of the COVID pandemic. So just go ahead to the next slide. What we do is we take a large amount of socioeconomic data, both that's publicly available and also that we purchase. And in general, we combine it with clinical data. And I say in general because the COVID pandemic, I'll go through that story with public health, that was an exception. But in general, we combine it with clinical data on patients. We've had over 40 million patients go through our data universe. And so the models are very representative of the entire population in the US. And we also have, obviously, a significant number of interesting endpoints. How this works then is we have in the AI solution, the socioeconomic data combined with the clinical data to see patients holistically. And when the pandemic started, within 2 weeks, we had a COVID vulnerability map, and you can see this in the next slide. We had a COVID vulnerability map that we stood up and made publicly available from March 13th, I believe it was, when when a lot of the lockdowns hit around the country. We had the map available, and in the matter of the first couple months, we had over 2 million hits on our website. You can go ahead to the next slide if there we go. So this is an example of the COVID vulnerability map that showed down to the block group level specific areas and neighborhoods that were particularly vulnerable if the patients in that neighborhood contracted COVID. And the vulnerabilities were connected to socioeconomic and essentially the non-clinical aspects of their vulnerability. How do we do that? And this is rather interesting. With the large amount of patients that we already had represented in our data universe, we also had clinical endpoints. So we started with saying, well, what is the storyline for patients who were in the community and they ended up hospitalized due to a respiratory illness, because we knew COVID was a respiratory illness. even with all that we didn't know in March of 2020. And so we mapped it to influenza as an endpoint, because if we were waiting for hard outcomes from COVID, it would have been another 6 to 9 months before we had sufficient data and outcomes in order to do that modeling. So we modeled it against influenza. Patients who are at risk for influenza, transmission was similar, hospitalization and the nature of the hospitalization was similar. They end up with respiratory failure and in the ICU on a ventilator. So the endpoints, the course is similar. And so we looked at the vulnerabilities that were tied to influenza. And then the next step that we did is we took out the clinical components, because when you're looking at public health, you don't have clinical data on a lot of these patients, but you have the socioeconomic data down to the neighborhood level. And so this is how we generated the map that was accessible. People could click on it, zoom in. And this is an example where in a very small area in Los Angeles County, you have disparities just around in neighborhoods just around the corner from each other, with the ability to understand this is an area, if we're getting a hot spot now in this county, this is an area where we would want to intensify awareness, education, extreme isolation. In those cases, perhaps meals to the door instead of them having to go out and get food and those sorts of things, especially for the vulnerable and frail in that area. So this is how this was used. We don't have a handle on all of the ways which people used it, but we know it was used around the country. We had academic organizations contacting us. But the most interesting story, we discovered it probably June, early July of 2020. We found on YouTube that there was a medical student that was using the neighborhood level data that we were providing on the website and mobilizing an army of medical students to do community outreach and reaching out specifically to neighborhoods where where the population was more vulnerable. This was done in South Carolina. As a result, they demonstrated impact. They began to do a more rigorous study and analysis around it. They demonstrated impact on the people that they called and were able to get a hold of versus the people that they called and were not able to get a hold of. Obviously, the intervention mattered. And then the people that they didn't call, but were not identified in the high-risk neighborhoods. So they had several cohorts like that, demonstrated that the risk stratification of those neighborhoods was effective, that the high-risk neighborhoods had higher rates of admission than the low-risk neighborhoods. But then secondly, the intervention of making a phone call and talking to them, finding out what their risks were in more detail, actually impacted the rates of hospitalization. Let's say a diabetic and they were afraid to go out and get their medications, they could end up hospitalized for uncontrolled diabetes, perhaps, and not necessarily for COVID. So they were addressing a number of things there, but it started with, who do we target? This is the role of artificial intelligence. Obviously, intelligence is embedded in that phrase. If we better understand populations, and then we can pinpoint risk within those populations and mitigate that risk, then we're doing something impactful. And this has the public health ramifications to it. So this is the role in our space, at least, for artificial intelligence applied to public health, is to understand populations so that we understand who they are, where their vulnerabilities are, and then mitigate those risks as a result of understanding it with enough granularity, with enough specificity that what actions I take are going to make a difference. There's a trap here. There are a lot of general sources of information around vulnerability that we found are not granular enough and not specific enough to actually impact the population that I'm working on. So you can burn a lot of resources and effort based on having some information you think is good, and it actually is not specific or detailed enough that it makes a difference. So we found that the granularity here, and as demonstrated in the study that they're publishing now, actually helped to make a difference. If we go to the next slide, you can see, we'll just zoom out here on the left hand, the whole United States. It's what you would expect. It's a patchwork quilt, and there are hot spots and there are areas of low risk throughout the entire country. But that's a very macro level. And so what we did is, when you zoom into the into a state, we benchmark the state against itself. So when you're looking at counties or even down to block group level, it's all benchmarked within the state. Otherwise, an entire state could be purple, which is high risk, because it's relatively high risk compared to other states. So we demarcated, and this is relevant to public health approaches. Entities have to be geographically defined. And we geographically define the states as separate entities so that the risks, so I live in Michigan, we're specific to the state of Michigan and not to the whole country, because that wouldn't be as useful, because the public health efforts are state and local efforts typically. Although we know, of course, the federal government was involved in the crisis of a worldwide pandemic. And then you can see, going from the neighborhood or from the city view, and this again happened to be in Michigan, in the Detroit area, down to a block group level, and you can see very specifically within that block group where one neighborhood was high risk and then right around it was lower risk. And these were for the various socioeconomic drivers and vulnerabilities within that neighborhood. So this illustrates how this could be used, not only for COVID, but also for future public health implications as well. You can go ahead to the next slide. What this allows us to do when we understand vulnerability, and that's pretty tiny print there. So I'll give you, actually, if we go 2 slides back, Catherine, you might be able to see, it's still pretty tiny, but you can see there that the vulnerability reasons or drivers down the right-hand side. The top socioeconomic influencers included factors related to income, environmental risks, low school performance. They say, well, why is that relevant? Because low school performance is associated with health literacy. Health literacy is associated with understanding, why do I need to do what I'm doing? And that's very much associated both with patients who understood how to practice isolation and also those that may or may not have gotten the COVID vaccine. So health literacy, school performance, all of these things are tied together. That illustrates how the socioeconomic factors in a neighborhood drive vulnerability and risk, even to the point where people living in a particular area could be higher risk for hospitalization. And to back that up, another analysis that was done, we found the patients in the high risk group in neighborhoods and at the county level down in, it was in New Orleans, the risk for mortality in the vulnerable populations was more than 2 times higher than the lower risk neighborhoods and populations in the same area around New Orleans. And so we it was a very high level, but a mortality analysis, as well as we started to have some outcome data later in the year in 2020. And again, that's just to substantiate. So this sounds good. If you say, well, I've got this vulnerability map, it must be right. But you need to, at some point, you need to validate it, look at outcomes in order to say we really are able to count on it. And it isn't just a cool visualization. So go ahead, forward 2 slides again, Catherine, for me. And I guess the last point I'd like to make here is there are ways to do it right and ways to do it wrong. What we've seen is that when we aren't specific enough with the insights that we get or detailed to the right level of granularity, then our conclusions can be either too general or wrong altogether. And this is a study that Yale published in the last couple months, actually, showing that some of the socioeconomic data that they had on patients did not fully explain the outcome that they were looking at. And this is an important component around social determinants. We need to have not only the right data, but the right granularity of data on patients, both at the public health or population level, and also at the individual level, in order to take action and know that that action is going to make a difference. And this is what this study exposed, is that not having the right level of granularity on patients will cause us to take a lot of actions, but not necessarily get to the right outcome. So I'll end my comments there and turn it back over to you, Catherine.
Great, thank you to both of you. Those are very interesting presentations. And I know that we have some questions coming in through the Q&A box. which I'll get to in just a minute. So if anybody else has questions for John or Betsy that you want to put in the Q&A box, go ahead and do so. And I will get to those in just a second. But I wanted to open up with a couple of questions for both of you to kind of set the stage on what the future is, which I think we're all really interested in talking about here. You both talked a lot about the impact of COVID-19 on public health systems, but I wanted to ask you, because so many of us really learned how outdated the systems were that public health departments were using as COVID hit. And I think a lot of us were really surprised by that. And so it seems pretty aspirational to go from a lot of what was paper-based before COVID to using on an everyday basis, cloud computing, AI, some of these more innovative technologies. So do you think that we're close to where these types of technologies that you guys have both talked about are able to be used in the public health systems as a norm?
I can start. In 2019, 3% of our entire budget in the United States for healthcare was spent on public health. That's really tiny considering how much we spend. So a lot of what I'm seeing in our customers is a spectrum. We have a couple customers that had the resources and the means to really, bleeding edge, jump to cloud computing and some of these really advanced technologies to try to serve their constituents. And then we have a lot of customers that were just, they just needed a life raft and they're like just now getting back to shore and trying to stand on solid ground again and figure out what's going on. So we have kind of a spectrum. I think everyone in the public health field would like to get to what I call the run stage. We crawl, walk, run stage of cloud computing and advanced technologies. But we're kind of in a time period right now where we're somewhere along a spectrum of that. And so, my job is really to meet folks where they are and try to get them from crawl to walk and walk to run. So John, I don't know if you had any thoughts on that.
Yeah, no, that's excuse me, that's spot on. I would I just have to and mirror it with our customer experience as well. I'd say there are three components that you want to think about. You absolutely need the core technology as a foundational component. You also need, at least for when it comes to artificial intelligence, I'll say consumability. You need to be able to take the artificial intelligence that a data scientist created over here, have it be consumable or usable by the right folks. And then the third thing is not just people, but it's whole operationalization of those insights. And that's where I think we're weakest right now. So the technology is there and it's very consumable, whether it's website or other services that Jvion or other vendors can provide. That's not the issue, but it's how it's operationalized. And I think the infrastructure is still missing there from a people and process standpoint. But if you've got the three legs of the stool, people, process, and technology, I think the technology is no longer the weak link.
Maybe it's more so the siloed system that we've kind of created between public health and clinical.
Yeah, and you can start with, again, I see public health as geographically defined entities. Maybe the whole country can't do something, but there are some states that are good. Maybe a state can't do something, but there are some counties or local municipalities that are effective. And they're a microcosm then of what can be done at a larger scale.
Very interesting. And so you guys have kind of touched on this, but I want to talk about what you see as the future if these are fully implemented, if these insights, the data insights, or the technologies to gain the insights from the data that you both have touched on, if these are fully deployed across the country, what do you see as the future for public health? And would we be prepared for a future, hopefully it won't happen, but would we be better prepared for a future pandemic?
I guess, do you want me to go first, Betsy?
Sure.
I definitely see that with all of these things in place again, some words that come to mind, much more dynamic than we were. So we were struggling to be reactive. You go from reactive to becoming responsive to becoming proactive. And I think that's where, if we're really good at this, that's where it will be in the future. In a dynamic a competency being developed will be nimble and proactive or anticipatory, so that the earliest clues, and there was some AI that was working early in 2020 that recognized there was an outbreak occurring outside of the US that AI picked up. It wasn't ours, but there's other AI that's out there. If it picks up a clue like that, then the next question is, well, what do we do, or how do we react to it? That's where all these things working together, and you've got the capability for rapid response is all possible in the future.
Yeah, I echo that. You know, a really future vision story that I love to tell is I've worked a lot in Medicaid, have my MPH, and did my dissertation, my practicum on childhood obesity. So, you know, a great future state I would love to see in the proactive realm is, listen, we know we are really good, well, pretty good at treating acute clinical conditions. We can do it. You go to a hospital, it happens. What about the underlying stuff? So if we look at a population and we see, you know, using John's example of some AI, a trigger or a piece of data that says, hey, there's something risky here. How can we look beyond just the acute clinical care to really identify how we can assist the public in being healthy and engage them in their own health journey, so that things like food and housing and job security and all of the other things that we know make up the rest of our lives play a part in how we look at a diagnosis, for lack of a better term.
Yeah, and I know that we have some questions in the Q&A box on some of those chronic conditions too, which I'll get to, but I think it's very interesting insight for some of our attendees here today, because you're both industry companies that have partnered some level with public health entities, county, government, state, and how can industry work more with public health entities?
Yeah, our philosophy, which I love, is customer obsession. And we have a really interesting anecdote of, in a lot of meetings where we're talking about solutions or programs or ways to do things, we have an empty chair in the room for where the customer would sit. I think an industry, especially because of our passion and because of all the work we've done, you know, we get really excited about solutions and solutioning and programming. What, in my opinion, we need to do with the public health arena is really meet people where they are and have that empty chair in the room and ask them, what is it you need? We know everyone would love to have AI. Is that what you need right now? You know, maybe we just need to have better bus lines. I mean, I don't know what that answer is, but I think the best way for industry to partner is to meet our customers and constituents where they are, and look at the data that can point to how we get to a solution versus building things and hoping they will come.
Yeah, I'll just echo that. Industry's temptation is to try and sell something every time, and it keeps us from being very effective listeners sometimes. So a true partnership means we're trying to understand and solve problems together, and it doesn't always mean that industry is going to sell something or gain something at that level. But what we do gain is, if we're altruistic or missional, is that we gain a win for everybody. So the partnership, as a pure definition of partnership, to me is critical for that to be seen.
What I appreciate about both of you is that you are really looking at true partnerships for sustainable solutions. I think during COVID, we've all heard a lot about solutions that were stood up very quickly to react to the emergency at hand, which was COVID. But myself included have concerns that those solutions won't be replicable for the future and might not be sustainable. And so I appreciate, thank you both for your insights on COVID as well as the future. And I want to get to, we have quite a few audience Q&As coming in here. So I wanted to get a few of these, especially talking about some of the non-COVID data. We have a question in here. I think this was for John. Did you do any analysis of the combinations of comorbid conditions in your heat mapping? I know you had some of the vulnerabilities listed. Did that take into consideration any clinical data, or is that more on the population data side?
Yeah, how we started, and the only way we could do this is we took existing populations of patients that we had, and they had clinical data. And then we could see in particular areas of the country, there are higher incidence of comorbid conditions. There's more diabetes and obesity in certain areas than others. So we didn't have clinical data for every area of the country or from patients directly, unless they were in our data universe. But we could, extrapolate is the wrong word, but there's a data science-y process where we can understand patients and infer or impute properties to them, and populations also. Hope that makes sense. But we were able to understand some of the comorbid clinical risks for populations in an area, even though we had none of that data on populations in this exercise. In general, we do. But for this, when we went to a block level community vulnerability map, we couldn't have PHI, we couldn't expose PHI, obviously, to the public either.
Just to add on to that, and John, would love your thoughts on this. You know, I think I come from a data analytics background as well. I think, you know, sometimes we tend to let perfection be the enemy of good enough or directionally accurate. And so, you know, I think there are steps towards looking at comorbidities and having some of that, you know, research article level data and outcomes. But to start, being directionally accurate or, you know, good enough is a good place to begin the journey, to really try to nail some of that down. Because I know, you know, policy sometimes can get in the way of that perfection goal.
Yeah, that's right. You know, especially when you have to be moving at the speed of the crisis. It's good to be a little bit conservative, not doing harm when you're making what you think are data-driven decisions. But it's going to be a learning, and it's a learning process, and it's going to be iterative. I remember in the first few months, I was in a physician group where everybody was keeping their groceries outside for the first 24 hours because they were concerned about fomites. So, and we learned it's probably not too much of an issue, and people could start eating their groceries again the same day. So we learned along the way.
Yes. Yeah, I think that was it's always funny to think about now. There's a question here. I think it was specifically to John, but I'm going to pose it to both of you, because this is something that we talk a lot about in public health, is that so much is run on the local, state, county level, that you might build a solution, Betsy, for one state, Minnesota Health Department. However, if you are like in DC, and this person says in Chattanooga, Tennessee, where you're in an area that so much of what impacts your health is not bound by state lines or county lines or locality lines. So how have each of you, or how do you think that in the future that will be addressed? Because I don't think the funding or the public health system is going to all of a sudden become federalized overnight. So have you faced those issues, and what do you think that the future is, given our modern world?
So I have seen it certainly in the health information exchange realm, where we're having health information exchange cross state lines now, and they've merged, you know, to become one entity, but each gets separate state funding. I also have seen a lot, you know, the big blocker that I've run into is the policy piece. So lot of concern around privacy. We have seen there's an entity in North Carolina that was able to get mental health, STI, and pregnancy data together to treat mothers that have mental health and are at risk for, STIs. That to me is like the trifecta of sensitive data, and that got to yes. So I think the key is really bringing parties to the table together, separating out. I mean, there's always a way, especially when I think about it from the cloud computing standpoint, you can divide and conquer the funding piece. That's easy. Do it based on population or whatever your legislature's comfortable with. But getting to yes on that data sharing component, there are success stories out there now. And I think there's just the key of allowing that data exchange in a way that's meaningful to prove out that return on the investment from any sort of state or federal level.
That's great, Betsy. I think you actually just even answered another question we had in here around AWS's ability to combine data, public health and clinical data. So it's really like, yes, you can.
Yeah.
But from a policy standpoint, it depends on what the state rules are. And, even because you can go, if you're interested in discussing more privacy issues, you can go back and look at the recording of our last webinar on privacy issues. But most everybody knows that at the federal level, HIPAA serves as a floor, and there are many more state-specific privacy laws that apply in this scenario, and even more now with a lot of the issues that happened with COVID. So that was a great story to answer second question. John, did you have any thoughts along those lines as well?
For us, it's the same issue. Policy drives the availability of data sources. And so crossing state boundaries can certainly be a little bit more of a challenge. So for us, states are, and our footprint is not as large in the public health space. It's more in the provider and the payer community, which do cross state boundaries. So we haven't run into that as much of a challenge because we're dealing with a population, that could cover 3 states, and we have all those patients. So we don't typically take a geographic approach. It's a population approach based upon patients given to us. If that makes sense? That's how you would have to overcome this. Let's say an HAE covers 3, an area where 3 states or 4 states all touch. The HIE is going to have more power to bring the data from those different states than the local municipalities or individual counties.
We had an HIE speaker on our privacy webinar too that spoke to how they were able to do it in like the New Jersey, Pennsylvania area. So that was a really good example of how HIEs are able to bring the government side to the table.
Yeah, and sorry, just one more point on this, Catherine. Thinking through that customer lens and meeting people where they are, I think a lot of the times, especially in the healthcare arena, we like to make decisions for people because we have our M's and our masters and our doctorates and all the things, and that's great, and we should be doing that. But I also think it's important to ask the actual consumer what they think before we start making decisions around whether we can share data or not, because as someone who just experienced a cross-country health issue, I want California to send my provider in Colorado my data. I want that. And so I think if we actually ask the people at the center of that triangle, that they might say yes, they might say no, and that can influence our decisions a lot easier than just assuming for them.
Yes. I think there's some specific answers in here, which I'll, if you guys want to take any answer, look in here, but one question that I wanted to get to from some of the questions that were submitted ahead of time is, what do you guys see? You touched on it a little bit, but the value proposition, how do we move the needle on whether that's public health leaders or it's state elected officials to fund these types of projects. How do we get these technologies adopted more widely? And I'll let you guys take it from there, but is it the value propositions that we've shown during COVID? Do you have other thoughts?
I think there's really a leadership question here. Now, it takes leadership to cast a vision, to generate passion, to call out the burning platform or identify clearly not only the problem, but then to galvanize people to help be part of the solution. So leadership in some aspect is absolutely necessary. It could be public health, even if the funding in a department is low, and I see the question here, but the leadership is able to bring collaboration, to bring people together, to convene forums where there are resources, where there are, say foundations or large industry partners or provider organizations and payers. Somebody's got to be able to lead and bring those organizations, those entities together to help to solve the problem collectively. This can't be done unilaterally or through one approach, like just the payer taking the lead, or even public health just driving it by themselves. I think a collaborative approach with strong leadership is essential.
Absolutely.
But I think that's what we're missing right now.
No, I agree, John. And I think the other piece, I mean, depending on what state you're in, it goes all the way from maybe you have a visionary legislature or political figure that is willing to put their political capital in the game, or you may need a more grassroots level movement, to Dr. Frownfelter's point of maybe it's the Hospital Association, Provider Association, and HIE in the state that really try to drive legislative change in order to make both funding and policy a little more apt towards the whole person and patient-centered care movement, which includes the public health aspect, because Dr. Frownfelter's whole presentation was on the fact that we need to look at population data to identify where to provide care. So I echo John's statements, and I also just would add that as well, that I think it's state by state, but we have to be willing to put in a little bit of work on the grassroots side if that's what's necessary in order to bring together a collaborative.
Yes, that is great. I don't do a lot of state work, but we, in case anybody on the phone hasn't joined our previous webinars, EHI put together a public health modernization task force, and we're going to be releasing later this spring some recommendations around how to move some of the adoption of these technologies forward, mostly focused on a federal level, but make sure you're keeping an eye out for those too. With that, I just want to ask, any last thoughts, Betsy or John, that you'd like to, some parting thoughts for our attendees here as we wrap up?
No, just thank you so much for your time and for listening to us. And we're all kind of in this together. And so, please feel free to reach out if there are any other questions around how we can potentially work towards the modernization utopia, if you will, or how to even get into the crawl stage.
Great.
I'll just add, I think the new, that's my, if anyone has a dog at home, my dog is leaking right now. He's whining, and so I apologize. The new pandemic, if you will, I would call it, is going around the country, is this concept of health equity and health inequity. And these same principles and concepts can be applied to vulnerable populations and health equity and health inequities, if you will. And so I think there's opportunity today. We don't need to wait for the next pandemic. Everything that I shared and discussed, and everything also I think that Betsy shared and discussed, apply to this new challenge in front of us and to the next one as well. So the time is now for us to act.
Great. Well, that's a great note to end on. And I think your dog probably has to go outside.
Or needs a Frisbee thrown something, but
Well, thank you all for joining today. The recording will be available on our website after today. We'll also be sending you a quick survey. Emma, if you can just bring up the last slide, if you don't mind. She might have stepped out, but I think it says that everything will be on the website, and we'll be sending around a quick survey to all the attendees today. So thank you all for joining. Keep an eye out for our next webinar on our public health modernization series. And with that, I will let you all go. Happy Tuesday.
thank you all.
Thank you.